Thank you for inviting me to give this talk. And this is, of course, a topic that's very well studied by surgeons and medical oncologists, and radiations are sort of lost cousins who are sitting on the side. So I'm going to try to justify or try to give you some perspective of radiation use in ovarian cancer. So, ovarian cancer is the second most gynecological cancers diagnosed in North America, and we know surgery and chemotherapy are the mainstay of ovarian cancer. In fact, radiation was used at some point, so I will try to give you some perspective of how radiation was used in the past, and potentially what are some of the areas how radiation can be used in the future. All right, so I have no financial disclosures. So the learning objectives for today's talk is to really try to describe what role radiation has played in the past, and also trying to familiarize with some of my colleagues, because I only see about 3-4 radiation oncologists here, what these terms really mean. Whole abdominal radiotherapy, IMRT, Dr. Viswanathan has talked about some IMRT, and the newer technique called SBRT, or stereotactic radiotherapy. So at the end, if I have time, I will try to discuss the role of SBRT in the current paradigm of treating cancer, especially ovarian cancer management, and potentially identifying some opportunities where we can collaborate with our colleagues. So in general, to give you an idea, where does radiation fit in cancer treatment, and I'll take any cancer treatment, we think of radiation as two separate entities or boxes. All of us think in boxes. So one is the curative intent box, where the goal is to really eradicate cancer cells, either microscopic disease or macroscopic disease. And typically we give very high doses in that context, sometimes up to 50, 60 gray, higher than 60 gray. And the treatment courses are quite long, 5, 6, 7 week long courses, once daily treatment. Whereas the other box is the palliative, where the goal is really to help patients with symptoms. And this can be pain, bleeding in the pelvis, in the abdominal cavity, in the bone. And the treatment is generally given either a single fraction in a single day. It can be given on the same day, or 1-2 week courses. So not really 5 to 6 week courses. So I will start with just first the role of radiation therapy in the curative context in the ovarian cancer. And since we're talking in Toronto, so I'll plug in the Toronto connection here. Dr. Alan Dumbo, a lot of people will know here, was a radiation oncologist who worked here at the Princess Margaret Hospital and then Sunnybrook Hospital, who was a pioneer in role of radiation therapy in the ovarian cancer. He spearheaded 2 randomized controlled trials in late 1970s, early 1980s, and he, over the years, published many retrospective series that really led us to understand what radiation did and what it didn't do in ovarian cancer. So one of the first trials was within the in the pelvis. Of course, I have to say all these trials or the therapies are in the adjuvant setting after the patients had undergone debulking surgery. So the first randomized trial was by Dr. Dembo, published in 1968, I believe, or 1968 to 1972. He randomized 63 patients here at Princess Margaret Hospital. Of course, all of them were early stage, stage 1A. Half of these patients received pelvic radiotherapy, which is a 5-week course of radiation, or were observed. At the same time, GOG group also did a randomized trial where they also randomized these women to either pelvic radiotherapy, or the standard of care chemotherapy at that time was melphalan, or just observation. All the patients were early stage, stage 1A. There were no difference in patients who received any kind of treatment or were just observed, which formed the basis that in very early ovarian cancer with appropriate debulking, you don't really need to give any adjuvant treatment. And of course, we see that in clinic these days. But what do we know about ovarian cancer? It doesn't really stay in pelvis. This picture from Nature Reviews really shows that ovarian cancer can metastasize to multiple different areas of the abdominal cavity, in the peritoneal surfaces, serosal surfaces, lymphatics, everywhere. So the other trial that was done by Dr. The other rationale that was developed during that time after the first pelvic radiotherapy trial to give radiation to the entire abdominal cavity. So this top diagram really shows a rough diagram of where would we target the radiation. The squiggly line, or the line I drew by hand, is the reflection of the peritoneal cavity. That's where we want to give total radiation. And the box, the line around it, was really the portal fields of how we would, the radiation oncologist in the 1960s and 70s would deliver the radiation by just a single beam or two beams from the anterior and the posterior aspect. And the black and white picture is one of the pictures that I took from internet, because I didn't treat this back in the day, is really they would draw the field these patients were treated with right on patient, and those two circles that you see are the areas where the kidney would sit, so you can potentially shield the kidney, because this is what would be lead to toxicity eventually. So there were at least few retrospective studies done in patients or experiences reported of patients treated with the entire radiotherapy, the entire abdominal cavity. But there were also two randomized trials in this series, and one of them again was by Dr. Dembo here, another one was from MD Anderson. The patients that were accrued in this trial were from a little bit higher stage than 1A, so 1B to stage 3. And they all received pelvic radiotherapy after appropriate debulking, surgical debulking. Some received, were randomized to receive chemotherapy. In PMH, they received chlorambucil. In MD Anderson, they received melphalan. Again, these are the chemotherapy drugs that were the standard of care at that time. And of course, one arm of the study received whole abdominal radiotherapy. Again, these treatments were 5 to 6 weeks long after surgery, along with chemotherapy. At least most of these, both of the randomized trials did show there was improvement in survival. They didn't give any numbers. These studies were old. They didn't really specify. The overall survival was 25% better than, that's the extent of reporting in those studies. The MD Anderson study, on the other hand, showed that most of this improvement was in stage 1 patients rather than stage 2 or stage 3. But certainly there are some retrospective series, and this one from Salt Lake City was one of the largest series that did show that there is some improvement in patients who received whole abdominal radiotherapy compared to just the pelvis alone or observation. So what was concluded in the 70s was that certainly abdominal pelvic radiotherapy does demonstrate some of superior outcome measure, regardless of what you want to take it. Is it just the relapse-free survival or overall survival or the disease control? Especially in patients who've had adequate debulking, and the key point they made was the minimal residual disease. So they didn't really talk about patients who had some macroscopic disease. There's no randomized data to suggest if there's macroscopic disease, what do patients do? Of course, we now know there are second debulking surgeries, but at that time, there were some retrospective series that looked at what happens to these patients who had some disease still visible on CT scan, or some disease that was left behind at the time of the surgery because it was inaccessible. So they found that the size really mattered when radiation was delivered to these women. So if the residual disease was less than 2 centimeters, those patients did better. Of course, we know that smaller the disease is with radiation or chemotherapy, the better the outcomes are. Second thing is, where the disease is left behind, is it in the pelvis versus in the abdomen? Pelvis, we can often deliver higher doses of radiation just because there are not that many critical structures within the pelvis, so that we're able to deliver higher dose of radiation. We all know that higher stages do generally worse, so the lower the stage, they will do better with any kind of adjuvant treatment. And all these, I've put the references down there. These are all the retrospective series that certainly gave us these conclusions. So why did radiotherapy really fall out of favor? I mean, some data was showing that this is doing better because the toxicity that these patients experienced was very high. More than 65% of the patients had acute complications, either GI-related complication, myelosuppression, liver-related complications. So about half of these patients, 44%, had some kind of radiation-induced liver disease. 14 to 15% of these patients had chronic diarrhea or chronic GI problems, and serious late bowel complications that requiring surgery was about 5%. So that's one reason. So how about the benefit? So we talked about there's some benefit, but it's really in very limited patients, as I talked, in a low risk, earlier stage 1 or 2 patients, or patients with minimal or no gross disease are the patients that really benefit from the radiotherapy. Not being able to deliver high enough dose, especially in the abdominal cavity. We talked about the radiation dose needed to sterilize the microscopic or macroscopic dose with the curative intent is really 5 to 6 week long course, 50 to 60 gray, but we can't deliver that in areas where the kidneys are in the way or livers in the way. And also, of course, at the same time, we started to get data that systemic therapy was at least equivalent or with lower toxicity. And this was one of the first papers that showed that in a randomized fashion that when systemic agents were used with pelvic radiotherapy, even though there was no benefit in overall survival, disease-free survival was better, but most important, toxicity was less compared to the whole abdominal radiotherapy. And then finally, we had this new kid in the block in the 70s. In 1978, the cisplatin was approved by FDA, and it was starting to being used in every kind of cancer, and of course, in ovarian cancer as well. This became quite popular, of course, with much lower toxicity compared to melphalan, as it was shown in these two papers. One of them is a randomized trial, and of course, with a better survival and a response rate in patients with ovarian cancer compared to the standard drugs used at the time, which was melphalan. Radiation oncologists were feeling too left behind, so they thought, why don't we combine cisplatin with radiotherapy? We didn't do any better at that time either. In fact, the complications and the toxicity rates were still higher. Instead of 4.5% to 5%, it went to about 9% rate of serious late bowel complications when cisplatin was combined with radiotherapy in women with ovarian cancer. So by this time in the early 2000s or late 90s, radiation completely fell out of favor in ovarian cancer. So radiation oncologists essentially just continued to work through it. There's multiple publications in 2001, 2002, 2005. How can we use radiotherapy if not as a first line after debulking surgery or in combination with chemotherapy, maybe in patients who relapse after chemotherapy? That's where we need to go. So this sort of depicts what happened, what I've talked about, how radiotherapy was the mainstay up until 70s, and chemotherapy has really taken over for the ovarian cancer after surgical debulking. But at the same time, radiation techniques have evolved. So we've gone back to develop better technologies, and we've talked about radiation being delivered by drawing on the patient physically or drawing on a 2D picture where radiation should be targeted. By 1980s and 1990s, we started to incorporate 3D imaging, CT scans, and MRIs to really delineate where the radiation should be delivered and which organs should be targeted and which organs can be spared. By 1990s, we were starting to incorporate technologies that started to shape the beams around these critical structures. And by 2000s, we started to incorporate these higher level technologies called intensity modulation, where we can actually not just avoid the target structure, we can change the intensity of the radiotherapy beam that was going through these organs. So that really gave us some hope that we can start to incorporate radiation back into the paradigm of ovarian cancer. And also, by 2000s, now we're talking about even more advanced techniques called stereotactic, where we can really identify the target more precisely and have even smaller margins around the radiation rather than giving the entire abdomen. So this is just an example of how the intensity modulation has been used to deliver radiation. Remember I showed you the picture where the entire abdominal cavity with two beams from the front and back received radiation. Here, The red is the high dose of a region where the high dose goes, and blue and green are really where the low dose of radiation is being delivered. And using these higher technology techniques, we can modulate high doses and low doses. The blue area is the liver, so we can really spare that. The spinal cord in the back is also can be spared. This next column over, it's showing that the kidneys are being spared, so we can do this now. Not being done fully because it's not really reported. There's only one paper that I could find with 16 patients, although they report very low toxicity, but it's really early data. So my take on whole abdominal radiotherapy, even with this new IMRT technique, is this is really some preliminary work, and it's not completely reported, although some groups are slowly doing it, but I don't think it's fully reported. There is significant reduction in acute toxicity, but it's still difficult to assess if there's any improvement in late toxicity. It's too early. So it's not really ready for prime time yet, I think. So where does radiation fit in ovarian cancer? So I think this is really a salvage option rather than upfront adjuvant option. At the time of recurrence, in fact, when patients have failed first-line chemotherapy, second-line chemotherapy, third-line, they've undergone maybe 1 or 2 or 3 debulking surgeries. And how do we deliver radiation rather than whole abdomen this time? We talk about involved field, only the areas where there's a risk of a recurrence after the surgery, or in the area where the surgery cannot be done. So those are the involved field. So this may include nodal regions. For example, if there's a pelvic node, so you want to irradiate entire pelvic nodal chain, that would be involved field radiotherapy. And the goal is really to use radiation after you've done surgical debulking or some cytoreductive technique using some chemotherapy. This is definitely not whole abdominal radiotherapy though. So this sort of picture really shows you the difference. The old technique of whole abdominal radiotherapy in the middle, the IMRT-based whole abdominal radiotherapy, and on the left, 2 sort of pictures of involved field radiotherapy. One shows the nodal regions being irradiated, yellow being the para-aortic chain, and blue being the pelvic nodal chain. And one of the in the middle column is just a area just on top of the right psoas muscle where you target the only area you want to target, and also the subcutaneous tissue. So there has been some experience, and one of the first ones is from the MD Anderson Cancer Center, where they did use involved field radiotherapy after patients failed. They've had debulking surgery. They've had at least, on average, 3 courses of chemotherapy. The radiation dose was at least 45 to 68 gray. Remember, I told you for these, this is still considered curative intent, so you have to have 5 to 6 week long courses, so it's a 5 to 6 long week course. And they did find that the patients had a long overall survival of up to 40%, and these are the patients who've had failed multiple lines of chemotherapy. And when they looked at in-field recurrence or control, 70% of these patients were controlled where the radiation was delivered. Similarly, Washington University published their data. They also show that there is excellent local control, and in some patients it does provide benefit and improvement in survival. UT Southwestern has shown their data that 5-year overall survival is upwards of 30% when patients are treated with this kind of technique after they failed on average 10 courses of chemotherapy before being considered for radiation. So like I said, this was really a lost cousin who's making a comeback. So this is one of my patients I just treated earlier this year. So she had at least she had intraperitoneal chemotherapy after debulking, then she had systemic agents. She still recurred. On the left, that's a large recurrence just in front of the right psoas muscle. You can also see a small nodule in the subcutaneous tissue. Gave her just what I call involved field radiotherapy using IMRT technique, and 2 months later the CT scan on the most right shows almost complete resolution of the treatment. So radiation does work in ovarian cancer if we can deliver it appropriately. So this is just a summary slide for cytoreductive surgery, because we often know, and we talk with our surgical colleagues, that second cytoreductive surgery is important for these patients who recur. There are no randomized trials, so this meta-analysis sort of serves that. They pooled together 40 surgical series, about 2,000 patients, and they found that in all those series, optimal surgery was only achievable in 70% patient, and complete surgical resection was only possible in about 50% of patients. So therefore, even in patients who do undergo cytoreductive surgery, there's a role for further localized treatment, and that localized treatment is potentially radiation therapy. So it could be involved field radiotherapy or the newer technique called SBRT, or stereotactic ablative radiotherapy. So what is SBRT? You've all heard and you've referred and maybe even told some of the patients without talking to radiation oncologists that we'll get you treated with SBRT. So it's a very highly precise form of radiotherapy. It requires high quality of imaging for planning, as well as daily imaging capability to ensure the delivery of radiation is where it's intended. You must account for internal target motion. A lot of time in the older techniques, we didn't account for internal target motions, such as breathing or the bowels that are moving. Typically with SBRT, we're talking about higher dose of radiation in each treatment. That's the reason we account for daily internal motion. It's 5 to 8 gray per fraction, which is about 3 to 4 treatments of conventional radiation in a single treatment. And it can be done in less days. It's often we think for now it's suitable for small targets just because we're getting more experience with it. This is a picture that I took from this group, Kunas et al., who treated this woman with ovarian cancer right in the middle of the abdominal cavity using what we call CyberKnife. That's just one way to deliver SBRT, using about like 50 or 60 different types of beams. But the goal of this picture is to just show how conformal and how tight the radiation doses are around the tumor. And so that's why you have to be very careful when we deliver this. So this is just a table to really show the differences. When we talked about whole abdominal radiotherapy, most of the time the average dose that was given was about 30 gray, because that was the limit of most of the organs, liver, kidney, and the fractions used were about 15 to 17. Dose per fraction was low. 3 to 5 weeks it took for these women to be treated. Involved field IMRT, again, 5 to 7 weeks of radiation, higher dose, the goal is to achieve cure. SBRT, on the other hand, can be done within 1 to 2 weeks, maybe only 1 or 2 fractions, or up to maximum 5 fractions. And sometimes it can be quite effective. So there are some early series in gynecological cancers. This is a study from by Kunas et al. That treated 50 women with SBRT. Half of them were ovarian cancer. They did find that rate of clinical benefit in patients who were treated with SBRT was about 60 to 70%, and they defined it as the patients who had complete response, partial response, or stable disease. Another group that treated about 80 women with ovarian cancer with SBRT found that the complete and partial response was up in 3/4, 77%, and they had no grade 3 or 4 toxicity, so very low toxicity. I have to reinforce that these are the women who were treated with multiple lines of chemotherapy, and they had previously received at least 2 or 3 times cytoreductive surgeries. So to summarize, SBRT is a useful tool for the setting of macroscopic disease that may not be amenable for surgical resection and provides excellent local control. But most of the data is still preliminary. So we do need to have more prospective studies. There are about 3 or 4 registered studies on the NCT trials. Most of them are for recurrent cancers or after failure of multiple lines of chemotherapy. But I think maybe we need to incorporate SBRT in the earlier paradigm of radiation during first or second line of chemotherapy when we see these cancers. Maybe we may see some incorporation of SBRT with immunotherapy. This has been done in other settings, melanoma, lung cancer. Maybe we may see some abscopal effect. I'm sure a lot of radiation oncologists talk about it, but that may be something we may talk. But that's the future. Hopefully we'll see some more radiation in ovarian cancer, but it's a talk of future discussion. So thank you.
Thank you, Dr. Taggar. We may have room for one question.
Oh, just a comment. Thank you for those interesting. The pictures you showed at the beginning, Dr. Dembo had me draw some of those lines, and that's whole abdominal radiation. But the black and white picture is actually a different technique altogether. It was called moving strip.
Yeah.
And what it was is they would have 2.5 centimeter strips. They treat, and every day they'd move the beam
That's right.
down by.
That's right.
And then they'd get the whole abdomen.
Exactly. Yeah. No,
So it's
I didn't want to. I
it's a
didn't want to
different-
differentiate.
Okay.
But that's a whole discussion.